All right. Good evening, all. I hope everybody can hear me loud and articulate. Good, good. Thank you for responding. All right, guys. The chat is open for the host. So in case you have any questions and concerns, please let me know. We have 1 hour of lecture and I have a lot to cover. Good evening all to everybody. My name is Dr. Parijat Kumar. I am the founder of International Sports and Orthopedic Manual Therapy. And I welcome you all to our medical evidence-based exercise prescription. Whether you are a physiotherapist, a chiropractor, osteopath, personal trainer, physical trainer, anything, exercise prescription, you can't get away from exercise prescription. And we in our day-to-day life also kind of work on ourselves. We go to the gym or walking or running, etc., etc. So evidence-based exercise prescription becomes very, very important. In case you have any questions and concerns on any of the slide, you're welcome to put this in the chat box. We will try to answer as the time allows. Okay. And just letting you know, we will be going a little bit over the board over the time because we have a lot to cover. We have a lot to share, but try to understand this is just a 1 hour free live lecture. More details will be definitely involved in our full medical evidence-based exercise prescription course. Okay. So we can cover, this is just an introductory course, introductory lecture to our medical evidence-based exercise prescription. Okay. All right. Somebody wants to ask me, what does it mean by medical evidence? I like that question. Medical is because we all are medical experts or allied health experts. Evidence-based, there are certain evidences that says that what kind of exercises and what kind of muscles you should do for proper training. Okay, I'll give you an example of the evidences and as we go through it. Okay, that's a good question. All right. I know people might have a lot of questions in this, and believe me, the video recording of this lecture would be posted on our website, and our website is theisom.com. Many of you might be knowing it, and there are people from our cohort as well. So you're welcome to see our website. We can mention that in the chat box. Website is theisom.com. You're welcome to see our entire American faculty, okay, and see what courses and what lectures and what manual therapy program we are starting very soon in March that you guys can join in and learn in detail. Okay. All right. So let's start with the lecture. Just give me a second. I'm multitasking over here. All right. We'll discuss everything. All right. So we'll start with the lecture. This lecture has been designed and presented by myself, Dr. Parijat Kumar. I am a physical therapist. I've got my training in India as well as in US. I have practiced in US for 4 years. Okay, I've done all my registered clinical exercise specialist by American College of Sports Medicine. So we have a lot of references from American College of Sports Medicine. Okay, because I'm a registered clinical exercise specialist from them. Okay, and I'm also a certified spinal manipulative therapist. I'm currently practicing in India, and we have this company kind of registered in US as well. So we bring all our US faculty under one roof and provide you the most reasonable and most evidence-based courses under one roof. Okay. You want to check us, you can check us on our website, theisom.com, email us if you have any query or WhatsApp us on the number. Okay. All right. We'll start with the lecture. So first, let me just tell you that the content that we are presenting right now, it's a legal copyright of ISOMT. So please make sure that you don't replicate, copy, or share this to anyone. All right. One more thing I would like to add with this free live lecture is that it is mostly confined to the orthopedic musculoskeletal approach. Okay. Now the exercise prescription in cardiovascular or in pulmonary settings, in cardiological settings, in cancer settings, they all can vary. Okay, even in the sports or on field or off field. So this particular lecture is confined mostly towards the orthopedic musculoskeletal. We are not discussing the cardiopulmonary or the cancer related or certain medical conditions related like hepatitis, liver problems, stomach problems, which all will be included in our detailed course. Okay. So in 1 hour, we can just consolidate, and this is an introductory live lecture. And what you will take home after this lecture is this. Okay. I know people wanted to know what we will get. So it's this you will get. All right. So after this lecture, you will know which type of exercises to recommend and in what conditions sometimes, which will include certain universal compensation patterns. So like we are humans, bipedal animals. So we have certain universal compensation patterns. Okay. So you will get to know that what are the common compensatory patterns and according to which you have to train the muscles. Okay. Participant will be able to monitor and progress the patients according to their resistance tools, their number of repetitions and load. Participants will learn how to create a healthier environment for their patients. They will learn additional treatments in conjunction with the passive therapies that you might have been doing in your day-to-day settings. You can do your modalities, you can do your soft tissue treatment, but exercise is an important and integral part. Okay. You need to know the diagnostic part before you jump onto your exercise prescription, and we will discuss all that. You will also learn to avoid the recurrence of the problem. We will discuss about how to target certain structure. You can actually target certain structure, and we will discuss that. Okay. We will discuss that about the cartilage, the tendon, and all that stuff. Okay. All right. Just give me a second. All right, guys, if you are not able to hear me, please check your internet connection. And because I guess I'm articulate to everybody. Everybody can hear me? All right. So yes, we will be discussing about the kind of a structure that you can actually target with certain high quality of exercises. Okay. We will be discussing a little bit about the psychological factors, like what exercise will have an impact on your psychology and your hormones, and dietary involvements a little bit is very, very important. Okay. But we will discuss all these details in our courses. It is very difficult to discuss all these details in 1 hour lecture. Okay. All right. So I tell my patient that I prescribe them a drug, which is called exercise. Okay. So this is in a funny way that I tell them that you like taking drugs. Okay, let me prescribe you a drug called exercise. Okay. And you know what? The side effect of the drug is that it will actually help and regulate your blood pressure, your blood sugar levels, your pulse. That's a side effect. And you will get stronger muscles, bones, weight loss, better mood and confidence, bowel and sleep habits will improve, and you will look and feel better. So that is the side effect of taking this drug called exercise. I mean, this is in a funny and sarcastic way, but make sure you educate your patient that these are the things that this drug can have. Okay. Now, the adverse reaction of this drug, you can sweat. So if you don't want to sweat, please don't exercise. You can enjoy yourself, but up to an extent if you overdose it or overdo it, or sudden death. Now, please don't say that to your patient because it is extremely rare. Okay. And the best way of taking this drug is it is very easy to self-administer. You can take it anytime, 24/7, morning, day, night, anytime you can administer this drug, which is called exercise. Okay. So please help your clients and educate your patients about this drug, which is called exercise. Okay. All right. Okay. Should I exercise every day? Well, I don't think so, because everyday exercise is not good, because your body, your liver, your muscles need rest. Okay. So I don't want everybody to be exercising every day, whether it's you or any fit person or of your clients. Okay. All right. We'll move forward. Everybody knows about this. I don't need to explain any of this. Exercise is the medicine. Exercise is the medicine. So please explain your clients that you will have to exercise. Now, just on a funny note, people say, what's your favorite exercise? Oh, chewing. Chewing is my favorite exercise. No, I know your mastication muscles are kind of working over there, but please don't tell your patients to do this. All right. Okay, dokes. If I'm going too fast, guys, or if I'm going too slow, you can let me know. I will slow it down. If you have any question and concerns, you can let me know, but we have to kind of finish on time as well. All right. Now, people confuse with physical activity and exercise. Okay. I'll very simply, I'll give you an example of my mother only. My mother is a homemaker, and she has a kind of a body type. So she tells me that, oh, I don't need to exercise. I already do a lot of activity at home. And I kind of take care of the home as well. And there are many ladies or many males who kind of take care of their home. But you need to identify those people, whether it is a physical activity or whether it is an exercise. Now, what's the difference? The difference is you're walking. Now, walking can be a simple physical activity. It can be an exercise as well. But you need to explain your patients or your clients that your exercise is a subtype, which is in a form of a structured, planned, and a repetitive bodily movement that should be done in a proper disciplined manner. If you don't have that discipline of doing exercises, the results will not be there. Please understand that. Okay. So please differentiate the patients or your clients that, okay, you might be working too hard at your home or in your home, doing all your household activities. We appreciate that. We respect that for your family, but that includes under your physical activity. That's not an exercise. Okay. Yes, their muscles are working in that, but they need a structured, well-planned exercise regime, which can be done again and again. Okay. Now there's a simple fun quiz I would like to ask you all. Okay. In this particular video, which muscles do you think we are working on? I have a subject over here. So which muscles do you think we are working on? Just mention me in the chat box. I want you all to name the particular muscles. Tell me some particular muscle. People from our batches who are attending this, you can let us know. Trapezius, which kind of a trapezius? Rectus abdominis is kind of a, which is the primary muscle working? I'm liking the answer. Deltoid is not working over here much. Latissimus dorsi is also not working much over here. Upper trapezius is working, that's good. Middle trapezius is working, that is good. Serratus anterior is working, that is good. Those are good answers. Upper trapezius, middle trapezius, serratus anterior, those are working, perfect. And which muscles do you think? Okay, hold on. I'm getting a lot of answers. Good answers, guys, good answers. And which muscles do you think are being stretched over here? Which muscles do you think are being stretched over here? I can play the video again and tell me which muscles are being stretched over here. Stretch. Quadriceps, no. Latissimus, no. Serratus anterior is not being stretched, it is being worked. I'm getting some good answers. The answer is pectoralis. Yes, your pecs are getting stretched over here. Just see the movement. See the movement. It is externally rotated. So your pecs are being stretched, your pec minor and your major. All right. Good answer, guys. Good answers. I like that. All right. So this is called like a wall angels, or I like to call this exercise as a laughing Buddha exercise. And this is a very advanced exercise done for your scapular stabilization in your shoulder patients. And we will discuss about those exercises. All right. Okay, dokes. Now, before you start with the exercise prescription, guys, I want you all to diagnose. I want you all to diagnose and do a quick screening. Now, you have to keep an eagle's eye to observe, because people can have compensatory patterns. And you can continue the best of your soft tissue treatment, the best of your manual treatment, the best of your exercise prescription. But if you don't observe the faults and the compensatory patterns, it will be difficult for you all to get the results. Okay. You need to understand the walking or the gait mechanics, observe their movements. You need to understand the spinal movements that people do, and they can kind of deviate in different directions. You need to understand whether they are hypomobile or hypermobile. If a patient comes to me, I'll give you a quick example. Many gym patients come to me and they say that, sir, I have a stiffness in my shoulder. Can you please manipulate me? Or do you think I should stretch my shoulder and the muscles? Their stiffness can be because of the hypermobility. That's what the problem is, that these days people come with a stiffness, their brain is perceiving this as a stiffness, and you think, okay, let's pop it up. Let's be a chiropractor, or let's kind of stretch it. No, it's not going to help. It might aggravate the problem. And that's what we discuss in our basic and advanced foundation course, which will be in the month of March very soon, that you need to identify the factors which are leading to the hypermobility. And that's why the brain can perceive it as stiffness. You need to quickly differentiate between the muscular or the joint dysfunction. You can use manual techniques by doing a passive examination, or what you can do is simply, like say, for example, if I ask my patient to turn their head and they're not able to rotate their head to the right side and a little bit to the left side, excuse me. And now I passively assess my patient. Okay. I passively assess my patient and the patients are able to rotate both the sides completely. Now that tells me that the muscles are restricting the rotation more than a joint. Okay. There are certain questionnaires called functional movement screening. You can also use those functional questionnaires. Now in this video, if you can see the video, there's a person running on the treadmill. So this is a running gait video. Now, if I want to analyze this particular patient, I want to know the biomechanics and the kinesiology of it. So I need to see her heel strike. I need to see her foot placement, whether it is going beyond the hips or not. I need to see her hip angles and knee angles from AP plane and from a sagittal plane. So that's why I'm saying diagnosis, observation, examination is very, very important. And in her case, if I tell you, she is, now look carefully, she is having the heel strike beyond her hip angle, which is actually wrong. Because when you do that, there's a lot of energy expenditure. So you're not supposed to do a lot of energy expenditure when you're running or jogging or doing any sprint. So not a sprint, but a marathon, especially. So your heel strike should not be beyond your hip. That will unnecessarily spend a lot of energy, and energy will be lost. So those all small examination you should be worried about, so that you can properly do exercise prescription. All right. Okay. I told you, you need to see a patient how they are moving. You need to see them segmentally. You need to see their deviation and their compensatory patterns. So in this case, if you see this person, this is a sagittal plane view, and he's just bending forward. Now I want you all to see his pelvis and hips carefully. See the pelvis and the hips carefully. And I would like to know from you all, what is the dysfunction? What is the problem that this person is having in the pelvis that he's doing while bending down? I'll play the video again. Tell me the problem that this person is doing while he's bending down. I like that answer. I like that answer. This patient came to me with a back pain, and he's a gym going person. And see carefully that when he's bending down, what is he doing which is preventing him or having the compensatory pattern? I'm liking that answer. Lumbar is stiff. Can I know some more specific answers? There is pelvic tilt. Very good. Awesome answer. There's posterior pelvic tilt. That is the perfect answer. That is the perfect answer. Posterior pelvic tilt. Okay. So posterior pelvic tilt is happening when he's trying to bend down, and that posterior pelvic tilt is happening in the initial ranges. It should not happen in the initial range. And this patient had a kind of a lumbar instability diagnosis. So you guys who have told about the pelvic tilt, you have to see all that stuff. Okay. All right. All right. Any more questions? Yes, posterior pelvic tilt. That's correct. And yes, if you see one more thing carefully, I would like to make you all realize that when he's bending down, he is shifting his hips behind the ankles. So his calf muscles can be tight. And that's why he's causing a hyperextension of the knee. That's why there's a hyperextension of the knee. Because of the calf tightness. See the amount of the hip angle and his ankle. His hip is way beyond the ankle when he's bending down. So these small observations you will have to make. You need to identify the painful or the stiff areas. You also need to perform a sensory motor examination, which is a little beyond this 1 hour lecture. We will include that in our detailed course. You can do some sensory motor examination where you can ask patients to kind of stand on one leg, do some balance exercise or coordination exercise. Okay. Very important thing is a good subjective history before you start on any exercise prescription, and screening the patient is very, very important for a good exercise prescription. You understand? If you don't take a good subjective history and you screen your patient, your exercise prescription might go in vain. So please make sure that your history taking and your observation and screening is up to the mark so that your patients get benefit out of your exercise prescription. Okay. The last thing in the diagnostic screening is that I want you all to know about the universal compensatory overuse patterns. These can be also syndromes. Like I know many people like TFL. Many people like to work on the TFL ITBs. They want to do foam rolling. They want to do dry needling. They want to do soft tissues and all. I will talk about hamstring stretching and all. I will talk about hamstrings and other things. I know there are a lot of myths in the market that you guys don't take care of that, but I want you all after today's lecture and become an integral part of ISOMT and continue with the courses and in detail understand all these things so that you can help your patients and clients better. Okay. Now, what are the universal compensatory and overuse patterns? Let's discuss that quickly, and then we'll jump on to the exercise prescription part. Okay. Before we jump onto the compensatory pattern, I want you all to focus on the pelvic dysfunctions as well. We talk a lot about the pelvic dysfunction, and believe me, most of your lower extremity problem patients with a heel pain, knee pain, or hip pain, they will be fixed in 1 or 2 sittings just by working on the pelvis. Okay. You need to know about the eccentric deceleration that your gait cycle has. When you are coming from a heel strike to mid stance in a gait cycle, everybody's walking. Okay. So you need to know that which muscles are controlling them eccentrically. And that is the reason why those muscles get tight. That is the reason why your TFL and your ITB is tight. That is the reason why your peroneus longus is working eccentrically to control that pronation of the foot during mid stance. Okay. And all that we discuss in our detail in our courses, in our ISOMT and in the lectures and all. Okay. So muscle controlling the deceleration of your uncontrolled pronation during the mid stance of your gait cycle is tensor fascia lata. Your adductors, your external rotators, which is your piriformis. I know people like to come up with piriformis syndrome, but why piriformis is getting tight? Why tensor fascia lata or your ITBs are getting tight? Is it because of pelvic dysfunction? Yes. Is it because the muscles like to be tight or they are in a shortened position? I don't think so. They are working eccentrically all the time to control the descent of your uncontrolled pronation. Understand this, and pronation at the foot. Okay, that's why these muscles get short, hypertonic, they can exhibit trigger points, and they go into overuse. Now, you think working on these hypertonic muscles on the soft tissues and stretching them is kind of any issue? You can work on it, but that will not solve the root cause. The root cause is that you will have to work on the pelvic dysfunction. You will have to work on the pelvic and the core muscles, which is your glutes. And we will discuss about the glutes as well. Now, in this particular subject over here, I'm observing her from a frontal plane, posterior aspect, and I would like to see her pelvic. I would like to see her hip abduction. I would like to see her toe in and out, and I would like to see her knee flexion angles. So that is the motion analysis that you can do when you are observing and checking a patient from a sagittal or an AP plane. All right. All right. This is the most important slide that I want you all to take home. Now, there are other important slides as well, but I want you to take home this particular slide. What is the universal compensatory pattern? And these are the cluster of findings that I want you to know. Pronated right foot, right anterior innominate rotation, left posterior innominate rotation. And if people out there, they don't understand the meaning of these terms, I would appreciate and request you all, you're welcome to go on our website, theisom.com, and we have a pelvis and sacroiliac joint course over there, or we would be doing the pelvis and sacroiliac joint course very soon as well in our cohort, which is starting in the month of March. So if you don't understand these terms, you're welcome to join the pelvis and sacroiliac joint course or our cohort, okay? So left pubic would be superior, right pubis would be inferior, and L on L sacral torsion. These are the torsions of your tailbone, and these are certain innominate rotation. Can I have the spine, please? Thank you. Your lower thoracic can go into scoliosis to the right. Your lumbar can go into scoliosis to the left. You can have your right shoulder anteriorly and inferiorly, okay? And you can have left cervical scoliosis. Now, these are the universal compensatory pattern that you will find in all of them. Now, I have a spine quickly. I want to kind of quickly mention this to you all. This is my spine, okay? This is my spine. You're seeing from the front side. So this is called anterior innominate rotation. This is called posterior innominate rotation, all right? So we will discuss this more into our kind of our courses, okay? All right, but I want to know from the people that why are these cluster of findings are there? Why these cluster of findings are there? Why are these cluster of findings there? I want answers from you all, guys. What is the main reason that why we have, like, posture is just a, no, why right anterior innominate only? Why not left anterior innominate? If my posture is bad, nobody's posture is good. My posture is bad too. But why would I have right anterior innominate and left posterior? Why would I have that? Why there are different findings left and right? I'm getting some good answers. Yes, most of the people are right because of the dominance, because of the right-sided dominance. That is the correct answer. Okay, because we are mostly right-handed people, left brain dominant, and that is one of the reasons why these universal compensatory patterns occur in the right side. Now, if somebody is appearing out of the dysfunction from these, you have to really take that thing seriously and fix that dysfunction. Okay, so these are the common universal compensatory patterns that you have to identify in especially the right-handed people, but that doesn't mean that you don't fix them. Yes, we fix them. Okay, and as I said, if you're not able to understand the terminology over here and what are these, you're welcome to access our pelvis and sacroiliac joint course on our website or join our cohort. Okay, all right. All right, now how do you identify the compensation? Now, this is one of the video. Can you guys tell me that which muscle am I particular testing over here? Which muscle am I testing particularly over here? I want to know in the chat box. Quads. How come I'm testing quads? No, I'm not testing quads. Quads is in the front, guys. I'll play the video again. Which muscle am I testing over here? My one hand is on the hamstring. My one hand is on the gluteus maximus. Which exercise or which muscle do you think I'm working on? What are the answers? Gluteus medius, no. Rectus femoris is in front. Nope. Gluteus medius is not the right answer, guys. People who have answered hamstrings, that is one correct answer. Piriformis, no. Piriformis is not an extensor. You need to know your muscle function by heart. If you really want to do exercise prescription, you need to know your muscle function by heart. Okay. No, I'm not testing ITB band, please. Perfect answer. I am testing the primary muscle that I'm testing over here is gluteus maximus. This is a test where the hip extensor, the primary hip extensor is your gluteus maximus. So one hand is on the gluteus maximus and one hand is on the hamstring. If my hamstring fires before my gluteus maximus, that is a compensatory faulty pattern. The primary normal pattern should be that my gluteus maximus should fire before the hamstring. And that is a test that you can use. And many of the people with the pelvic dysfunctions come with this problem. Okay. So make sure you check the gluteus maximus, and believe me, 90% of your sports athletes, including runners, players, any other cricketers or any other kind of a sports loving person, they will have hamstring dominance. And what we start doing is we start stretching the hamstring. Do you think that is right? I don't think so. Okay. So please make sure that you are not doing the hamstring stretches, and we will kind of discuss that why. Because your hamstring, especially your biceps femoris, is also one of the muscle which is controlling the deceleration of the overpronated foot while in your gait cycle in the mid stance phase. Okay. So make sure you are not really kind of stretching the hamstring, because that will not get into the proper function. All right. Okay, dokes. Okay, can somebody tell me what this person is doing over here in the chat box? Can you tell me what is he doing? What is he trying to do? Tell me in the chat box. Good answer. Good answer. He is simply doing stretching. He is doing stretching. All right. So the question is, should we stretch? Should we stretch? Hold on to that thought. Should we stretch? All right, I will elaborate you that in my next couple of minutes. All right. So there are many theories of stretching, but nothing has been proven scientifically. And what the stretching is doing is that, yes, it helps to prevent the injuries. It helps to improve your flexibility, your joint range of motion. It helps to prevent the delayed soreness, helps to activate your mechanoreceptors, and helps in the coordination. But let's talk that whether it really helps in other aspects or not. So should we really stretch the muscles which are functionally adapted, short muscles? Okay. And I'll give you an answer to that. All right. Sorry. So if I give you an example, that say, for example, I have a patient who is a swimmer, and swimmer is doing like a butterfly stroke. Okay. So in a butterfly stroke, a swimmer can have a lot of hypertonic muscles, the pectoralis. So do you think sports athlete who is using a lot of pectoralis in their sport event is a good way to kind of stretch that muscles? Tell me in the chat box. Do you think people who are using their pectoralis in a butterfly stroke, or the cyclists who are using a lot of their iliopsoas, ice skaters and all, do you think we should really stretch those muscles? Yes or no? Good. No, we are not supposed to stretch those muscles which are functionally adapted. Okay. So please understand that it is not always good to stretch the muscles. And what we can do instead of stretching is like a dynamic cool down. We will discuss the dynamic cool down. You can do a dynamic cool down over there. And as Sarman stated, and we include that in our first basic and advanced foundation course as well, Sarman says she's a 80-plus-year-old lady practicing in US, and she has given a lot in the movement impairment syndromes. Her statement is shorten what is long rather than stretch what is short. Okay? Shorten what is long rather than stretch what is short. And that is what the neural concepts are. That's why I'm requesting all to kind of think about whether you have to stretch or no. Okay? Just give me a second. All right. There's a question. So people want to know that what the evidence says that you should actually strengthen, which is the weak muscle. It doesn't matter whether it is a short muscle or a long muscle. You need to focus more on strengthening rather than stretching. Please understand that. Okay. All right. We'll move on to the next slide because we have a lot to cover. We'll discuss that. All right. All right, that's what I was talking about. So here you can see that I'm kind of passively stretching the hamstring muscle, okay, and which should not be actually done. Why? Because your hamstring, especially your biceps femoris, is eccentrically controlling your tibia and your fibula, if you see the attachments, okay, and that's why your biceps femoris and your hamstring becomes hypertonic. And what we do is we keep on stretching the hamstring. Yes, it feels good, the flexibility can improve, but believe me, it further complicates the problem. It further complicates the problem while you're doing the hamstring stretch. And it has been scientifically proven, there are evidences. So what should be the main reason? What should be the main treatment? You need to strengthen the glutes. You have to strengthen the glutes rather than just stretching the hamstring muscle. Okay? All right. All right, we'll move forward. So people were asking me about cooling down and dynamic exercises. So this is something called cooling down and dynamic exercises. All right. So this is the dynamic exercise where you can simply ask the patients to perform lunges or simple lumbar rotations or simple jumping activity exercises. So a light dynamic muscle contraction is a better way of cooling down, which will help to regain the aerobic activity of the muscles. Okay. Low intensity cooling down exercise have shown 50% greater efficacy because they need that time to remove the metabolic waste. Okay. Stanley Paris said there are two methods, which one can be a sustained stretch, 15 to 30 minutes. We generally don't do that. And one is contract relax, where we are kind of doing the cool down exercises. All right. Okay. Now don't confuse your stretching with the warm up. Stretching generally is done for shortened muscles, and warm up is generally done for all the muscles. Warming up is like a skeletal contraction for your muscles. Here, the person is kind of just doing a forward lunge step. So this can be a simple warm up or as well as a cool down. Okay. All right. All right. Just give me a second, guys. There's some kind of an error. Sorry, give me a second. All right. Now, what are the exercise prescription principles? The exercise prescription principles is whatever exercises that you're going to recommend to your patients, you need to practice on yourself or your colleagues first. So whatever things you are doing, you think your patient will be able to handle it. I'll give you an example. If I'm doing the wall hinges that I showed you, it is quite difficult. Okay, so make sure you do the exercise yourself, practice that yourself before you start doing it for your patients. There should be no pain during the exercises. You need to connect those exercises with the day-to-day requirements or the functional requirement of my patient. My patient is a gym person or an athlete, so I will match those exercises to his functional requirements. You should not give more than 5 exercises for a body region, and you should always use the first session as a trial. The second session could be for the feedback or for any kind of adjustments. Now, there will be weight-bearing structures like your cartilage. So you need to treat those structures, which are the weight-bearing structures, in your weight-bearing positions. Okay, you need to do a high-quality exercises. Okay, high-quality exercises should be recommended. Excuse me. And you need to respect what the patients are or your clients are telling you. If they are tired, you need to stop. If they have pain, you need to stop. Okay. Can you give an example each for a positive and a negative feedback? So the positive feedback is somebody wants me to give them an example of a positive and a negative feedback. See, this depends upon the psychology and the motivational levels of your client and the patient. So positive feedback, obviously, as a therapist or as a trainer, you will have to work on people's motivation level as well. Okay, that will give a positive feedback. A patient can say, hey, yes, I'm able to do this exercise. But you have to tell the patient that I don't want you to working on your comfort zone. So if they're very easily able to do the exercise, that means they can be working in their comfort zone. So you have to increase the stress on their muscles in order to strengthen. And this comes with experience, that you don't stress them too much that they are like sore for the next 2 or 3 days. Soreness is good, but not too much of the soreness, because then you will have like a microcellular damage of the muscles. Okay. All right. All right. The next one is that you need to match those exercises to the patient's motivation levels. And I will tell you some psychological factors where it has shown that exercises can help fight depression, ADHD, attention deficit hyperactive disorders. And the number one thing that a physician, even in US, what they do is that if a person is having any kind of a psychological disorders, the first thing they tell them is to go and exercise. Okay. Now you need to train over a long period, according to Halton, to correct some faulty movement patterns. Okay. All right. So please make sure that you remember all these principles before you recommend your exercises to the patient or your client. Okay. All right. Okay. A fun quiz again. Now, very simple. Now see the rotation of the leg over here, and I want you to tell me that which muscle are we working on? Which muscle are we working on? I want to know. I'm getting some good answers. Quadriceps, which quadriceps? Good answer. Which muscles are we working on? People who have answered VMO, that is the correct answer. That's a perfect answer. So we are working on VMO, vastus medialis obliquus, which is a part of your quadriceps. Okay. Now, exercise prescription principles continue. What are the recommended rest periods? How much rest period your patient should do when they are targeting muscle strengthening? The evidence says that there has to be at least 48 hours of rest when you're doing a muscle strengthening in between your exercise prescription. There should be at least 24 to 72 hours of rest when you're doing an endurance training. So say, for example, I'm training a patient or an athlete for marathon. Now that's an endurance training or a cycling. I need to give them 24 to 72 hours of rest. You need to give more frequent rest in between your exercise bouts. And how much is that? 5 to 10 seconds only in between the sets of the same exercise to avoid for any anaerobic metabolism. Okay. Now, when the rest is there, what is rest? Now, rest can be in between the sets or in between the days. Now, that rest has to be of high quality. It can't be like the patient is like constantly moving here, there, and you are saying that that's a rest. No, that is not the rest. And there is some exercise physiology, because I did my master's in the clinical exercise physiology from States. So what does the exercise physiology says? It says that after depletion of your energy stores, the oxygen level that returns back to the normal is 10 seconds to 1 minute. Okay, 10 seconds to 1 minute. Now, replenishing the glycogen in muscles, that is around 10 to 46 hours. And that is why those rest periods are important. Replenishing glycogen in the liver, 12 to 24 hours. And last but not the least, I want you all to remember this, because there's a lot of misconception about the delayed onset of muscle soreness, which is your lactic acid. People think that it will take a lot of days or hours to remove for the lactic acid from your sore muscles. The evidence says that it only takes 30 minutes to 2 hours to remove your lactic acids. And that is not the reason for your delayed onset of muscle soreness. The reason for your delayed onset of muscle soreness is the microcellular muscle damage. And that's why you have to replenish that with the proteins. Okay. So that was the rest periods that you require during exercise prescription. Now, how much resistance to give? Now, this is subjective. Depending upon the patient's body type, number one, depending upon the patient's MMT or the manual muscle testing of that particular muscle, your resistance is decided. DeLorme in early 1900s, he came up with a concept, and this concept is actually practiced everywhere, which is called 1 RM, maximum resistance that can be overcome in the entire movement. I know many people might know it, but we actually don't practically test this. Why? Because of the injuries. Okay. Now there's a graph over here, if you see carefully, and I want you all to look this carefully. This is called Halton progression of the exercise. I'm sure many of you might be knowing this. Excuse me. So say, for example, if I see this graph and I want to train my biceps, and I think that one RM of my biceps is 50 kilos. So if I want to train the muscle in strengthening part, I would actually go with 35 kilos dumbbell and above, and I would like to do at least 16 or maybe less repetition. So see the left line, which says the percentage of the RM in the graph over here, and see the right line, which says the number of repetition. The higher the percentage of the RM is, the lesser the repetition you do. And what is 1 RM? 1 RM is the maximum amount of weight or resistance that can be overcome once in a movement. Okay. Yes, 48 hours of rest period is good for muscle strengthening. Somebody asked me that question. All right. Okay. So that is how you determine the resistance. And as I said, it also depends upon your MMT and patient's body type, whatever therabands, whatever weights you want to use. It will totally depend upon patient's function levels, MMT level, and your experience. Okay. How many sets we have to do? How many number of sets we have to do? Yes, DeLorme and Watkins. That's correct. Now, older studies suggest that minimum of 3 sets can be done with each exercises, but later on studies came out which say that 1 set can be equally effective in improving the muscle strength and size. So single sets can be done for the people who are untrained for the first 6 to 12 months. Okay. Yes, you will have to do multiple sets ranging from 1 set to 3 sets or 4 sets or maximum 5 sets of one exercise in order to gain in muscle strength, hypertrophy, endurance, or power. Okay. Now you don't really calculate 1 RM. You don't practically do 1 RM in the clinic because it can injure the patient. You estimate it. You estimate it, and you can actually ask your patient about the estimation, and you can do an MMT. And you kind of figure that out. You really don't practice and do the 1 RM just to prevent any injury. Okay. All right. A fun quiz question over there. I want you all to tell me what is the difference between these two movements. What is the difference between these two? So in the first picture or the video, he's doing the rotation of the trunk with knees together. And in the second picture, he's doing the same thing with knees open. What is the difference? That's what I want to know. Why? That's what I want to know. Why? So with one picture, he is with knees together, and with the other picture, he is with knees open. Why? What does it do? That's what you all want to know, because when you are checking the rotations, if you don't know whether the patients are keeping their knees open or closed, it can actually have an effect. Somebody says pelvic stability. I like that answer. Relaxed position. Why? Transverse abdominis. Nah. Reduced base of support. It doesn't have to do with any base of support. Yes, the range of motion is different in both the cases. Why? So I will tell you, in second case, where the knees are open, the thoracic rotation will be more. But why? Tell me. With knees open, the trunk rotators are more relaxed. That is a secondary answer. Guys, please check your internet connection. People who can't see the video, please check your internet connections. I'm getting some messages from the people. Please check your internet connections. I'll tell you the answer. When you open up the knee, it helps to gap your lumbosacral junction. And that is why you can perform more rotations, and there could be some hip rotations involved as well, when you have abducted, horizontally abducted the hips. And that is why this patient can perform more rotations of the trunk when he has opened the knees. All right. Now, there are certain exercise prescription for tissue specific. Okay, what are the tissue specific exercises and what are the principles? Well, it depends upon whether the patient is in an acute condition or a chronic condition. Okay, if it is an acute condition, obviously 1 to 2 weeks of repeated low intensity exercises have shown a better result with a proper rest period. And studies have also shown that whether many times your patients or your clients can ask that how much time it's going to take for me to strengthen this muscle. Okay, so you have to tell them that at least it takes 4 to 6 weeks after the initiation of the exercises for the muscles to show proper strength gains. Okay, patient education and therapist experience are very important when you are training the person in these tissue specific exercises. Okay, and I want you all to remember the last point, that it is always important for patients and educate them not to overdo it, and don't disregard the pain, which can lead to overuse. So that's why you as a doctor, as their therapist, you have to provide them repetitive instructions and warning signs. They can fall, they can overdo it, they can disregard their pain, etc., etc. Okay. So here we come on to the tissue specific exercise, which is your tendon. Now, tendon has a lower metabolic turnover, okay, and it is less vascular than a muscle. That's why the healing process of a tendon is like longer and prolonged. Okay. Somebody wants to ask how many number of sessions in 1 to 2 weeks. Well, if it is an acute case, I would not like to go more than 3 or maximum 4 times a week, because your patient needs rest from that acute inflammatory phase. I would not like to go more than 3 times or 4 times a week with a low intensity exercise. That's a good question. Okay, so tendon training, what we can do, the evidence suggests that when you are training or loading the tendon, you will have to use 40 to 60% of your 1 RM and do at least 100 to 200 repetition. Okay, with a higher intensity of the load, you can reduce the repetitions. Okay, and there are researches which says that in the initial stages of your tendinopathy or tendinitis, you have to use less eccentric exercises, and the more and more inflammation comes down, you can increase the exercises to like 3 exercises per session, and those exercises can be less than 30 seconds. You can rest for 5 seconds and repeat these eccentric exercises for at least 20 to 30 minutes. Okay, so eccentric exercises have more researchers on these tendon problems. Okay, and as I said, details will be discussed more in our particular course. Okay, we will have to move forward. Now, cartilage. Now, did you know that cartilage in your knees or in your joints can be trained as well. Okay, so cartilage, yes, they can be trained, they can be hypermobile, they can go into stiffness. And what are the signs of the overloading of your cartilage? That you can have a deep joint pain, you can have a loss of range of motion with some swelling, and especially patients who complain of joint stiffness or pain, especially in the mornings, especially your knee joint patient, especially in the morning, their cartilage would be gone. Now, cartilage is a weight-bearing structure. It can respond to the stimulus of compression and decompression. That is why you have to give these patients or clients the weight-bearing or non-weight-bearing exercises. And there are studies, a lot of studies which have shown with the positive effects of the exercises on the cartilage healing. Now, what is the dosage? The dosage is the load has to be 20% of 1 RM. I'll give you an example. Now, say, for example, in this particular video, the patient is doing a supported squats. See carefully. He's loading his cartilage. You can use a chair to support, or you can lean onto a gym ball to support as well. So that's how I like to do 20% of 1 RM with 1000 repetition. That's what the study says. Now, it is difficult to count 1000 repetitions practically. So how I like to do it is I tell my patients to do this particular exercise for at least 4 minutes or 3 minutes or 5 minutes without any muscle fatigue. If the muscles are fatiguing, you need to stop. Okay. And as I said, more details of the cartilage training will be discussed along with the tendon training. Yes, 1000 repetition. Now, nobody can count 1000 repetitions. So that's why I tell my patients, that's what the study says. And that's what there are many studies done on dogs or on animals where they have shown that these many of repetitions are required to stimulate your cartilage. Now, no, you cannot count the repetitions. So what I tell my person to do is just to kind of start with like 2 minutes or 5 minutes. Okay, that's how you do it. All right, just give me a second. Yes, sir. Guys, please see your internet connection if you can't see the video. So say, for example, in this particular case, if my patient can do a 150 kilo squat with 150 kilos, say, for example, I can do 150 kilo squats. Now, my 150 kilo squat is my 1 RM. So 20% of my 150 kilo is 30 kilos. So what I will try to do is sometimes there are sensors which can actually weigh that how much you are weighing, but practically it's not possible. So I would like to put 30 kilos of force and do that for at least 4 to 5 times. There are certain sliders that you can use. Here we are just using the gym ball to kind of a support. There are sliders which can change in the excuse me. There are sliders or total gym we say, which can change in the angles and you can alter the amount of the weight that you're putting. Okay. You can start with 2 minutes, 3 minutes, 4 minutes, 5 minutes. As I said, details will be discussed in the course. Now, what are the exercise prescription for muscles? It is a proper tissue. Okay. So for strength development, 60 to 80% of 1 RM would be required. Okay. Well, somebody asked me for the elderly. Yes, I agree with you that for doing this particular exercise in an elderly population would be difficult. What you can simply ask them to do is lean onto the ball. But if they are having some back issues, be very careful. You can do in a holding position. You can just ask them to hold onto a chair, just hold onto a chair and simply do this. Simple. Hold on to the chair and simply do this. If you have an elderly person. So respect your elderly person's back problem, or everybody will not be able to do this gym ball exercises. So they can hold on to something and repeat the same exercise. Okay. I hope that answer helps you, ma'am. All right. For strength development in muscles, 60 to 80% of 1 RM, 6 to 12 repetitions. For muscle endurance, your 30 to 70% of 1 RM, 10 to 25 repetitions. The same with power development and muscle hypertrophy as well. So those are the areas where you have to work on in order to help your patients with proper exercise prescription. Okay. All right. We'll move to now. This is a concise conclusion by American College of Sports Medicine. This table has been taken from American College of Sports Medicine 8th edition. Okay, which says that what is the mode, type, intensity, duration, and frequency. Because I'm registered from American College of Sports Medicine, we have read all through this, where it shows that whether the strength, hypertrophy, power, endurance, whether you're doing it for a beginner, novice, whether you're doing for an intermediate, or whether you're doing for an advanced person, and how much the loading should be done if you're training the strength. So I want you all to have a look on this table. What should be the volume, what should be the velocity, and what should be the frequency times per week. These all have been framed in one table through a lot of researchers. Okay. All right. All right. Now comes to the fun part, guys. Believe me, we will take, I know we are already on time, but give me 15 more minutes, 15 or 20 more minutes. I understand this lecture would help you with your day-to-day settings and exercises and practice. And just bear with me for 15-20 minutes. And I want to show you all the exercises over here that you can do. Now, how you can target these specific joints and muscles. Okay. Now, how we do it is occipitoatlantal. Now, many people have forward head posture. Many people have forward head posture. So you need to actually target your occipitoatlantal joint. There's a joint called occipitoatlantal. We really don't do the extension one because your occipitoatlantal is already in extension. But here I'm showing you the exercise for occipitoatlantal extension. You can start with 10 repetitions and you can progress to 10 to 30 repetitions, 1 to 2 sets. Okay. All right. I'm going to share this video and I'm going to demonstrate that on my subject over here. So see carefully, the patient's head has to be completely flexed over the chair. So the patient's head has to be completely flexed over the chair. Oops. And what the patient is doing over here is just protruding the head. Protruding the head. I will show you over here. I'm just kind of adjusting the table. Just bear with me for 10-15 more minutes, guys. Then we'll wrap this up. And we are going to share the quiz link in the WhatsApp groups for you all to attend the quiz. And that's how you will get your certificates. Okay. So here's my subject. I really thank him for helping me out. So his head is completely flexed. Okay. His head is completely flexed. And what I'm asking him to do is, can you protrude your head forward, sir? Easy, easy, easy. Yes. You see that movement? You see that subtle movement? That is what he's doing for OA extension. But we don't really like to do OA extension because in the forward head posture, your OA is already kind of fixed in extension. Okay. So what we are supposed to do? We are supposed to do the flexion. And how can we do that? All right. We can do it in this way. Now here, what the person is doing, this is the exercise that I would like you all to do in your forward head posture, people. Occipitoatlantal flexion. How you do that is completely rotate the neck, to kind of lock the cervical spine, completely rotate the neck. And what I'm asking him to do is just nod your head, sir. That's it. This is causing occipitoatlantal flexion. So let's do it on the opposite way. So turn your head all the way. He's turned all the way. And can you just nod, sir? That's it. Now you see the movement. Can you nod again? Yes. See that nodding movement. So nodding movement is this. No, not that much. A little bit. That's it. That's it. So see, that is called nodding movement, and that is causing the occipitoatlantal flexion. Now, when you do these exercises, you will have the patient rotate the head completely and then perform nodding. Perform a nod, sir. That's good. Easy, easy. You can start with 10 repetitions, 20 repetitions, and then 30 repetitions. That is called occipitoatlantal flexion exercises. Okay, good one. Thank you, sir. All right, I'm going to come on the chin tucks as well. All right. So upper cervical C1 to C3 rotation, very simple mobility exercise. The patient bends the neck all the way down all the way down. I'm sorry if I so the patient bends the neck all the way down and he's simply rotating the head left and right. That specifies the rotation to your C1, C3 when you flex the neck completely. Okay, you need to know where most of your rotations are coming from. Well, a person was asking me about the chin tucks. Well, chin tucks, I would like to start with supine because chin tucks in supine is pro-gravity. And then I can progress it to sitting, which is a gravity eliminated. And then I can progress that into prone, which is anti-gravity. And then I can add some of the resistance exercises or resistance band. Okay. All right. So here's the video of chin tucks, but slowly look what am I asking this subject for his mouth. Now look carefully, his mouth is a little open. Now why is that? Can somebody tell me why his mouth is a little bit open? That is what the research says. Because your sternocleidomastoid can be compensating for your chin tucks. The sternocleidomastoid can be compensating for your chin tucks. Yes, you can apply for cervical spondylosis. You can apply all these exercises for your cervical spondylosis. People have asked me on the chat. That is called chin tucks, and the mouth is slightly open. Can somebody tell me why the mouth is open? Slightly. Why the mouth is slightly open? Can somebody tell me? That is what the evidence says. No, this is not for the respiratory thing. Resting position of the TMJ can be one of the answer. Yes, good. That's a good answer. The research says that the reason why mouth is open is because it reduces the activity of your sternocleidomastoid. Okay, and if you see the eye contact, I have asked the patient to look up at a 45-degree angle, because that also says that when you are looking at a 45-degree angle, because your eye muscles are also working, and you open the mouth, your sternocleidomastoid activation reduces, and your chin tucks are more effective. Okay, all right. Now chin tuck with neck flexion. Your patients come to you with a forward head posture, corporate job, desk job. Their deep neck flexors are not having a proper endurance. Now, how this is a endurance test as well as an exercise, which is very difficult to do it. So what you do is you perform a chin tuck first, maintain that chin tuck, and ask the patient to lift it up. You maintain a chin tuck first and ask your client or your patient to lift that up. The normal duration of that hold for females is 29 seconds. For males, it is 39 seconds. That is what the research says. This is called a craniocervical flexion test with chin tucks with neck flexion. Okay, please can you lay on your back, sir? I'm going to show you over here. So chin tuck with neck flexion over here. This is an endurance test that I want you all to do with your patients. If your deep flexors are weak, just do the chin tucks without any compensation. So when your neck flexors are coming into the picture, you can do this exercise in an advanced stage. Don't do this in initial stages. So if you can see carefully, let me kind of. So can you see carefully? Yeah. The patient is performing a chin tuck, good, and maintain that chin tuck, sir, and just lift your head up, good, and hold it up there. Maintain the chin tuck. The moment he loses the chin tuck, the test or the exercise is over. I repeat, the moment he loses the chin tuck, the exercise or the test is over. So he need to maintain that chin tuck for at least 39 seconds, being a male, which is the normal for male, and 29 seconds for females. Okay, and that could be, and if they're not able to hold it, that's fine, because it is a difficult exercise. And your patient can hold it for like 5 seconds, 10 seconds, but tell them that your deep neck flexors are weak and you have to train on these muscles. And one day we have to get onto that 29 or 39 second level. Okay, so you can do this in an advanced stage. No, chin tucks, I don't think so, increases the forward head problem. I've never seen any article like that, so I don't think so, because you have to cause that upper cervical flexion, upper cervical extension and lower cervical flexion. You have to work on that. Okay. All right, we'll move forward. Now, these are a little more specific exercises for your cervical thoracic extension. Can you have a seat, sir? All right, so I'm going to show you from behind. So can you turn that, please? All right. Yeah, thank you. So if you see, I'll play the video first. This is for C71 extension exercise. Now see carefully what I'm doing over here. The patient performs a chin tuck first and then extend the head. So the patient will perform the chin tuck to kind of a C at their C5, C6 level. Okay, and then perform an extension. Deep neck flexors. Chin tucks are generally used for deep neck flexors, longus colli. That is the name of the muscle. So what we are doing over here, this is my C71. This is my C71. I like to ask my, can you turn a little bit aside, please? Thank you. So this is my C71 over here, this particular junction. I ask my patient to do a chin tuck and then maintain that chin tuck and extend your head. That is particularly causing the C71 extension. And I want you all to practice this exercise because many times 90% of your clients or your patients will have C71 flexion because of that forward head posture. Okay, so that's why we have to do this C71 extension exercise. Chin tuck and then extend. Chin tuck and extend. You can start with 5 to 10 repetitions. You can progress to 10 to 30, 1 to 2 sets. Okay, this is for C7 to T1. Now talking about T1 to T3. Okay, there's a lot of dysfunction at your cervicothoracic area. So how you perform the T1 to T3 is very simple. You ask the patient to rotate all the way. There should be more than 60 degrees of cervical rotation. There should be more than 60 degrees of cervical rotation. I can show you from that side. So rotate the head all the way, palpate the T1, T3, and extend your head. Good. That's causing T1 to T3 extension. Please relax and do it on the opposite side. Rotate and extend. Believe me, I want you all to do it right now on yourself. Do it right now on yourself. Rotate your head and then extend. Believe me, you will feel the restriction. Do it on yourself right now. Rotate all the way to the left, extend. Rotate all the way to the right, extend. You will feel the movement around your T1 to T3. Perform these exercises on yourself right now. This will be a good practice. All right. Start with 10 repetitions because these are mobility exercises and you can progress to 10 to 12 repetitions. All right. Okay, dokes. Now this is for shoulder girdle strengthening. All right. Please can we have a ball? Turn on your stomach on the ball. So over here, if you see carefully, the patient is in a prone position. You can do it on a simple bed if the patient is like elderly or they can't really do it on a ball. Okay. So you can simply do it on the bed. You can start with one hand if they can't do it with both the hands. Make sure they keep their neck relaxed. Okay. So that they are not using much of their neck extensors. Okay. You can start with 5 to 10 repetitions. You can progress to 10 to 20 repetitions. You can do 1 to 2 set and add some resistance. Now these are for shoulder girdle exercises. These are also called Y exercises. And you can do it in sitting, you can do it in standing, but I would prefer to do it in an anti-gravity position, okay? Because it really targets your lower trapezius strength. It really targets your lower trapezius strength, okay? So I want you to know, okay, sorry, I guess people are, all right. So I want you all to know that lower trapezius strength, strengthening is targeted with your Y exercises. And when it comes to T, where the arm should not go much into extension because of your rhomboids dominance, that will be your middle trapezius. And how we do it is, like I'll play the video over here, and if you see carefully on his right shoulder, now he's doing a little bit fast. He's doing a little bit fast. We need to do a little bit slower and a little bit more on the wider angle. But his right scapular lower trapezius is not firing properly. I'll play the video again. His right scapular lower trapezius is not firing properly. And how you do this exercise is, very quickly, I'll show you over here. So my subject or the patient is in a prone position. Now this can be on the bed, or you can do it one by one. The neck has to be relaxed. Okay. You can do it one by one. Just keep your elbows locked, sir. Keep your elbows locked and lift your one hand up. Lift your one hand up, just a one hand. Now he's a strong guy. He can do it with both the hands. So that's how the body types and the MMT can decide whether you have to decide on the, like, start with a tough exercise or an easy exercise. So, and the thumb should be up. It should be externally rotated in order to activate the lower trapezius over here. Now try with both the hands, sir. Elbows locked, thumbs up. Slowly bring it down. Slowly bring it up. Lower trapezius activation, very important for your shoulder patients. And now I would like him to do like a T exercise. Bring the hands just in a horizontal abduction. Don't bring the hands back because your rhomboids will start compensating over here. So make sure it is just 90 degrees to your scapula and thumbs up. If you see the thumbs carefully, I'll show you the thumbs over here. If you see the thumbs are up, and I want you to lift your arms up, sir. Lift your arms up. I'm going to take the, yep. Take it up and down slowly. We are working on middle trapezius over here. You can start with 5 to 10 repetitions. One hand or both the hands, you can start on the bed. If your patient is not comfortable on the ball, neck has to be relaxed. You can progress to 10 to 12, 20 repetitions, 1 to 2 sets. And then after that, you can add some resistance. You can add weight cuffs or you can add therabands or whatever you feel like. Okay? All right. Believe me, guys, there are a lot of exercises that is very difficult to include in this particular 1 hour lecture. I know everybody will have their own forms of exercises. All right. So make sure you can modify them. You can start with the easy ones, but I want you to make sure that you're targeting on the main muscles. Okay. Now this exercise we have already shown. This is called like a laughing Buddha exercise. I like to give that name, wall angels. And this is an advanced exercise. When you have got that middle and lower trapezius activation, then I like to progress to this particular exercise for your shoulder patients. I start generally with like 5 to 10 repetitions, progress to 10 to 20, 1 to 2 sets. And how it is done? You lean against the wall, you kind of a squat. If you see me, I kind of a squat a little bit. This. Squatting is important because it posteriorly tilts your pelvis. It posteriorly tilts your pelvis and it helps to reduce the firing of your latissimus dorsi. Okay, that's why the squatting is done. All right, I hope I'm loud and clear to everybody. All right, now this is the abdominal strengthening. Very simple. It is the same way that you do your MMT. Okay, now before you do your abdominal strengthening, your deep core, like your transverse abdominis and your multifidi should be activated. And I don't want to discuss too much in detail about in this particular lecture because we are already over time. But the first one shows your rectus abdominis strengthening, which is very simple, grade 3. So your hands can be forward, your knees can be flexed. You can improve like 5 repetitions, 10 repetitions, 10 to 30 repetitions, depending upon your goal. 1 to 3 sets, and then you can add some resistance. Now the next exercise or the progression would be hugging the self and then doing the same thing, because your center of gravity is going back slowly and surely. The third one is putting the hands behind the head. You can alter the hip knee angles and then performing the same thing. It's very simple, no rocket science. No rocket science. All right. This one I've already told you in the beginning. This can be also used for checking or for exercises. But in order to check for the glute max, I would like to check the G max first. So I told you the first muscle to fire on this particular action should be your G max. Okay. And how do you train the G max? I know people know this, but make sure that in the supine bridging, when you're doing a supine bridging, you have your G max and your erector spinae activation. You can start in supine with knees completely flexed. Can somebody tell me in the chat box real quick why the knee should be completely flexed? Tell me in the chat box why the knee should be completely flexed. Tell me in the chat box, guys. Inhibit, relax, lumbar, VMO. I'm glad most of you are answering that correct. Yes, in order to reduce the hamstring. I don't want my hamstrings to work over here. That's why my knee is completely flexed. My knee is completely flexed, and I want my glute max to be recruited. You can use a pillow for erector squeezes, or you can use a therabands to increase a little bit of the external rotation. Make sure your patient is not lifting too high. Okay, you can start with 5 to 10 repetitions, progress to 10 to 30, 1 to 2 sets, progress with some resistance band or some weights, or barbells, and then you can progress to one single leg doing bridging. Okay. All right, that makes sense to you all. Yes, good. In order to reduce the hamstring tension, I like to ask my patients to completely bend the knee. And see carefully, you can also add posterior pelvic tilts. You can also add posterior pelvic tilts in order to recruit your transverse abdominis and your G-max. Okay, so there can be a lot of modifications. Hip can be kept in abduction when you are trying to fire gluteus medius as well. All right. Now, this is an important exercise where I told you that there are certain universal compensatory patterns. You have to train these glute muscles, including gluteus medius, posterior fibers, which is called clamshells. Okay. Now, see carefully where the patient is stabilizing the hip. I want you to show this, please. So we are stabilizing the hip. Initially, the therapist can do that. And then the patient is just lifting the knee up. So look at the video carefully. So we are just lifting the knee up. Yep. We are just lifting the knee up. All right. These are called clamshell. It is very, very important to work on where you are trying to help your patients with pelvis and sacroiliac joint dysfunction. Okay. And how we do that is if I show you. All right. If you can see. All right. I hope everybody can see that. All right. So my patient's hip and knee is bent. Okay. I have to stabilize the patient pelvis so that he does not turn his pelvis back. And I ask him to just gently lift the knee up, sir. A little bit more. That's it. And he's not supposed to lift the knee higher because that will further externally rotate the hip. He's not supposed to do that. Okay. So he's gently lifting the knee, which is called clamshells, and it is a very good strengthening exercise for your posterior fibers of your gluteus medius, also called clamshells. That will really help you to focus on the pelvis and the sacroiliac joint dysfunctions. Okay, it's a very important exercise. That's why I've included these exercises for you all to take home, because these are important exercises. Nobody discusses that. All right. Now, advanced way to do your gluteus medius strengthening is this one, where the patient is in a sideline, his leg is extended, the hip is externally rotated to reduce the TFL activity. He has to elongate the leg to reduce the activity on the QL, because the patient can do the hip hiking, which is done by your quadratus lumborum. Okay, because this is a long lever exercises for your gluteus medius, the hip is in a little bit of an extension. So let's show that, sir. Okay, I'll show it over here as well. Okay, so what this subject is doing over here, if you see carefully, so I want you to bring your one leg back. See that? I want you to rotate your leg so that your tip of the toes are pointing up. Stabilize that, and the toes are pointing up. His leg is extended, and I want you to lift your leg up, sir. So what he's doing is he's doing hip abduction. So that is the function of the posterior fibers of your gluteus medius. All right, and that is a advanced exercise for gluteus medius. You can start with clamshells, therabands, and then elongate the hip in a long lever, externally rotate, and then perform the exercise for gluteus medius. Oops. All right, okie dokes. So those were the exercises, guys, that I want to demonstrate for you all, because believe me, there are a lot of exercises that we can actually do it for people. I know there was a limited number of activities and exercises, but you can modify them according to your patients, according to their problems. Now, the next topic, and we are wrapping this in like 5 minutes. Just give me 5 more minutes. I know we are over the time. All right, just give me a second. All right. So the psychological, and there are certain dietary factors that can be used for exercise prescription. You need to know that exercise initially, when there's a patient or subject starting the exercise, initially it could be a stressor. And it could be a stressor. That's why your norepinephrine level can increase. Your norepinephrine level and your cortisol levels initially can increase. Your stress can increase. But doing the regular exercises, okay, it can help regulate your cortisol levels and something called hypothalamic pituitary adrenal axis. Okay, it has a positive effect on your hippocampal neurotrophic gene, and it helps. That's why it helps to improve depression. And that's why when I was practicing with some of the doctors in US, and when I see there were children who used to come with a diagnosis of depression or attention deficit hyperactive disorders, the first thing a doctor tells them is to go and exercise because of the release of monoamines, tryptophan hormones, and beta endorphins. The studies have shown that the exercises have same effects as similar to the cognitive behavioral therapy. Okay, the compliance level and the motivation level of your patient should be matched when you're prescribing the exercises. Okay, and as I said, as far as the psychological factors and the dietary factors are concerned, this will be further discussed in detail in our muscle energy, in our medical exercise prescription course. Sorry, I'm kind of multitasking over here. So yeah, all right. Diet plays a big role. Your proper hydration levels, your electrolytic balance, your sodium, potassium, magnesium, your vitamin D, calcium, nutrients, they all play a big role in your exercise prescription. Because if you don't have a proper dietary fuel in your body, your muscles will not work properly. Okay, and as I said, details will be shared in the course. All right, thank you so much, guys. I know we are already over the board. More information will be shared in our proper cohort program and in our medical exercise prescription course. Okay, so our cohort is coming very soon. I would like to share information, and we'll quickly share the quiz link in our group. Okay, in all the groups. So our cohort batch is starting in this particular March, and if people would like to join and learn more about these exercise prescriptions and manual therapy and dry needling, they are welcome to visit on our website, theisom.com. Okay, we connect all the dots because exercise prescription alone or manual therapy alone will not help. You have to use a holistic approach of your psychological counseling, of the dietary thing, of your manual therapy, of your exercise prescription to help your patients holistically. And how you can connect the dots is by doing our one-year program cohort in our manual therapy, which is starting next month. And if you want to really join and learn more from our American experts, we have more American experts joining us. So we have Dr. Kelly Wilson, we have Dr. Stephen Ford, Dr. Reginald, sports guy, we have pelvic floor, etc. We have chiropractors, we have osteopath in our team. So if you really want to learn from our American experts, you're welcome to check on our website and our social media pages. And if you have any other more concerns and questions, you can contact us on our email, as well as our phone number, WhatsApp contact. And I would like to see you all in our full one-year batches so that we can make you better clinician to help the society in a better and an evidence-based way. Okay. I'm Dr. Parijat Kumar. Sorry for taking a little bit more time. I hope the lecture helped you. We will share the quiz link very soon. And I hope you help your people in a proper evidence-based way and in a proper ethical way. Thank you so much. Good night. God bless. Have a good night.